Sir, you are sharing the screen right now.
Yeah, 1 minute.
Sir, you can stop the sharing, sir, so that my flyer will be
Yeah.
visible. When I will hand over, you can share it that.
Oh, sure. Just 1 minute, I'll stop. Yeah.
Sir, it's sharp 2:30. With all your permission, shall we start this session?
Sure, I'm ready.
Okay, sir. Just give me a moment. Good afternoon, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. C. Sarath Kumar, sir. Sir has done MBBS, MS, PhD in male fertility, FECSM, FPSM, DMRD, DRCOG, DGLS, FCGP, DYN, CUS, and FCGP, and principal and professor and head of the Department of Reproductive Medicine and Surgery, Medway Institute of Medical Science, Saryaji Rao Road, Mysore. Consultant sexologist and fertility surgeon at Apollo BGS Hospital, Kevemunpur Nagar, Mysore, and New Pridarshaniri Hospital, Pridhavan Extension, Mysore. And today, sir is going to speak on a topic, management of erectile dysfunction. Let me tell you overview of the topic. The National Institute of Health described ED as the inability to obtain and sustain erection is strong enough to allow the unsatisfied sexual performance. It frequently has a significant impact on the interpersonal relationship, overall quality of life, and self-esteem. There is no standard first-line diagnostic test, therefore a history and a physical examination are usually enough to diagnose ED. To treat ED, one of the most adopt and healthy lifestyle, reduce concurrent vascular risk factor, and treat biological or psychosexual dysfunction either on its own modification and in combination with psychosexual therapy. To learn about recent updates on the management of ED, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah, thank you much for us. Good afternoon, all the doctors. Very warm welcome to you for this IJCP Meditalk series. Last month I had talked about the diagnosis of erectile dysfunction. Because erectile dysfunction is such a vast subject, we cannot clear the diagnosis as well as management in one single setting. So that's why I had restricted the first lecture for the diagnosis only. Now, I am going to talk about the management of erectile dysfunction. Thank you for us for a nice introduction. Now I'm going to start the session. Second. So this particular afternoon, I'm going to cover this management of erectile dysfunction in the following chapters. I will give a just brief introduction, definition, causes, risk factor, investigations, and general treatment, which I had done in the last lecture, just to complete the lecture, because some of you might have tuned in today only, might have missed my last talk. That's why I'm going to just take few minutes to introduce the subject again. After that, I'm going to tell you about the treatment options available for the erectile dysfunction, namely psychosexual therapy, medical line of treatments, injection line of treatments, surgical treatments, alternative treatments available, and recent advances available in the management of erectile dysfunction. And of course, I'm going to conclude the subject. So friends, let me again introduce the subject to you. That is definition of ED. What is ED? Recurrent inability to achieve an erection of a person. Once in a way, everybody gets erectile dysfunction. That is, once in a way, one may not get the erection. That doesn't come to the final diagnosis of ED because it should be recurrent. That is, failure should be more than 75% of the attempts. Then only it will be called as the ED. So inability to maintain an adequate erection is also ED. Erection may be there, but may not be able to complete the act of intercourse. And noticeable decrease in the erectile rigidity is also ED. So not only erection, the quality of the erection, that is the rigidity, also counts a lot. That is during partner sexual activity or masturbation. So it need not be restricted to the uh, only during the intravaginal sex. It could be also the other way, anal sex or oral sex, all the types of other erectile, other sexual activity, even during masturbation. If one is unable to get the erection, that also comes in the this one. That is, it could be partner or self activity also. So erectile dysfunction is not limited to the partner sex. It is also other types of sex. So what are the criteria to come to a conclusion that one has got ED? The partner factor should be ruled out. The relationship factor with the partner should be ruled out. Individual or vulnerability factors, that is sexual abuse, psychiatric conditions, depression, stresses, they must be this one eliminated. And cultural and religious factors, inhibitions, conflicted attitudes, they should be ruled out. And medical conditions that affects the erection, including the effect of drugs and medications, they should be excluded. These are some things, these factors are not directly involved in the erection, they are indirectly causing the erectile dysfunction. So they should be addressed first before addressing the erectile dysfunction of the person. That is why the criteria has to be taken strictly is so that our treatment is aiming at the other factors which are causing the ED. That's why all these factors, partner factors, relationship factors, vulnerability factor, cultural factors, religious factors, and medical factors should be ruled out so that ultimately we are left with the ED. Now let us just briefly know about the common causes of ED. Most of the heart diseases, clogged blood vessels, atherosclerosis, high cholesterol, high blood pressure, diabetes, obesity, they may cause erectile dysfunction because the blood vessels involved are same for both the conditions. And metabolic syndromes, condition involving high blood pressure, high insulin level, body fat around the waist, and high cholesterol, that is also one of the cause for ED. Parkinson disease, multiple sclerosis are also the common causes for ED. Many medicines which are routinely described may also cause ED. Peyronie's disease, that is development of scar inside the penis, also is one of the cause for ED. Sleep disorders, mental health issues, performance anxiety, they are also causes for ED. Treatment for prostate cancer or enlarged prostate, surgeries, or injuries that affect the pelvic area, spinal cord injuries also cause ED. So low testosterone, hypogonadism is also one of the major cause for ED. So these are the common causes for erectile dysfunction. What are the risk factors? Aging. As the age advances, erectile dysfunction is more and more seen. Sedentary life, no exercise, no activity, that causes ED. Smoking, tobacco use, they are the risk factors. Excess alcoholism is another risk factor. Substance abuse, drug abuse may also be a risk factor. Partner problem, misunderstandings, fights with a partner, they are risk factors for ED. How to diagnose? It is very easy. The person himself, he comes and says, I have ED. So detailed history will rule out the risk factors for ED as well as concomitant factors, that is factors affecting the erection. They have to be taken in the history. Physical examination is a must. Examine the penis and testis. Of course, general examination also. Blood and urine routine test should be done. And hormone test, especially the hormones connected with the sexuality, that is FSH, LH, prolactin, testosterone, and thyroid test, they should be done. Genital scanning, if required, scanning of the testis, scanning of the penis, and scanning of the prostate, if necessary, should be done. color Doppler of the penis to see the blood flow of the penis can be done, and other tests, if required, have to be done for final diagnosis of the ED. So, friends, I have covered just given the just introduction of the ED, so that directly I didn't wanted to start the treatment options. I just wanted to go through the preliminaries regarding the definition of the ED, the causative factors for ED, and the risk factors for ED, and other how to diagnose the ED. These are the things I have covered. Now I am going directly coming to the subject of the topic of the day, that is treatment options available up to date for the treatment of ED. So these are the treatment options available right now: lifestyle changes, psychosexual therapy, medicines, injection therapies, vacuum pump devices, other treatment options, surgical therapy, and next generation treatments. So these are the treatments available right now for the person who has got the ED. So this is the treatment algorithm. That is, first line is lifestyle changes, second line is medicines, and of course injections. Third line is injections, vacuum pump devices. If everything fails, then implant surgery or the vascular surgery. Friends, note that the 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 surgical line has to be kept in the end, not in the beginning. So what are the lifestyle changes? Most important is, if he is a smoker, ask them to immediately quit smoking. Because as you know, a smoker inhales about 3,000 different types of toxic chemicals and exhales about 4,000 different types of toxic chemicals. And most of these toxins are the endothelial breaking nature. That is, they destroy the endothelium, that is the delicate lining of the blood vessels. That's why every smoker must be warned that it will cause ED. And alcohol abuse, excess alcohol also causes ED. And drug abuse of any type should be stopped. And if one is obese, weight management is a must. And creating a healthy sleep routine is very good for the erections. And managing sleep apnea, exercising regularly, eating healthy diet. So these are all the basic concepts of lifestyle changes which will enhance the sexuality of a person, including the erection. And it may be a cure for the ED also. And regarding the nutritional supplements, most of the people who come to me, they will ask, what should be eaten? What food will increase the erection? So on. So more of the nutritional supplements, especially which contain L-arginine, L-citrulline, propylene, L-carnitine, flavonoids, zinc, vitamin D, folic acid, L-methylfolate, DHEA, ginkgo biloba, ginseng, or panax ginseng. These are the some of the nutritional supplements which enhance the erection. Herbal products, hygrophia, gokshura, ginkgobia, ginseng, panax ginseng, as of course ashwagandha, all set to enhance the erection. So apart from lifestyle management and nutrition, the next most important aspect of treatment is psychosexual counseling and therapy. This is very, very important aspect for men with stress-related ED. When the partner is involved in the therapy, the problem is resolved 50 to 70% of the time. That is, good psychosexual counseling of the partners may be the very good treatment for the ED. When the man must go through the counseling alone, the results are less successful. That is, the couple counseling plays a major important role rather than only one person going through the counseling. Psychosexual counseling is unlikely to be effective if a man drops out of the treatment after 1 or 2 sittings, because at least 6 to 12 sittings are required for complete psychosexual counseling and therapy. Just one sitting, one may not be getting the required results. Friends, the most important psychosexual therapy available today is the time-tested sensate focus therapy. Sensate focus is also been described as mindful touching or non-orgasm, non-arousal focused touching. That is the between the partners. If they start touching each other, that is a very good exercise that gives very good sexual stimulation and erection. Sex therapists may recommend sensate focus to couples who want to address problems related to body image, arousal, desire, orgasm, premature ejaculation, and DD. In other words, sensate focus therapy is recommended in all types of sexual disorders, including desire disorder, arousal disorder, orgasm disorder, premature ejaculation, and ED. Now coming to directly to the drugs. Most of the times when the person comes to you, he immediately demands a prescription. He doesn't want to give history, doesn't want any investigations to be done. He doesn't want any counseling, psychotherapy or anything. What he wants is a prescription. Sir, give me a very good tablet. This is what usually most of the patients who come to you for ED ask. So what are the drugs available? There are oral agents, mainly phosphodiesterase type 5 inhibitors, oral phentolamine, apomorphine, yohimbine, intracavernosal injections, prostaglandin, alprostadil, papaverine, intraurethral, alprostadil. These are the drugs which are available in the market. And coming to PDE5 inhibitors, the most popular one and the first one which came to the market was sildenafil citrate, came as Viagra. Now hundreds of other companies are manufacturing the same medicine, and it is available in 25 mg, 50 mg, 100 mg tablet, as well as they are also available as soluble tablets also, and they have to be taken 1 hour before the sexual activity. The window period is 4 to 6 hours. Absorption is delayed by fatty meal. So that is the sildenafil citrate. If it is taken after a heavy fatty meal, the absorption is delayed. The second drug of choice is tadalafil, available as 5 mg, 10 mg, and 20 mg tablet. It has to be taken 30 minutes before the active sexual activity, at least, of course, 1 hour also. And the window period is 36 hours. Absorption is not affected by the food. The other drug available is vardenafil. It is available as 5 mg, 10 mg, 20 mg. It is also has to be taken about 1 hour before the sexual activity. The window period is 4 to 6 hours. The absorption is delayed by the fatty meal. So hundreds of brands of PDE5 inhibitors are available in the market. Some of the ones which are very popular in India are Viagra, Manforce, Vigor, Manforce, or the Power Viagra, Megalis, Viagra, Manforce Styla, and tadalafil available are Modula, Edisave, Mildfil, Efil, Tadac, Cialis, Tadaflow, Zydalis, etc. The second generation medicines, other than the tadalafil and sildenafil, are avanafil, lodenafil, miridenafil, udenafil. All these are available in Indian market now. They are quite expensive compared to the first order of medicines, that is the sildenafil and tadalafil. Whenever the first order of medicines fail, then the second generation medicines can be recommended. And whenever there are side effects for the first order of medicine, one should switch over to the second order of medicines, that is avanafil or lodenafil, myrodenafil, and udenafil. Melanocortin activators, they are the latest drugs. They are still in the infantile stage. They are in the experimental stage. And larger studies will be necessary to demonstrate the safety and overall effectiveness of these drugs. And they are being tried. And it may come to market in a year or two. So friends, this is the flow chart of the people who do not respond to PDE5 inhibitors. What to do if a person doesn't respond to the PDE5 inhibitors? In the first level, increase the dose from 50 mg to 100 mg. If it doesn't work, change the drug from sildenafil to tadalafil, tadalafil to avanafil, avanafil to udenafil. Go on trying it. One thing, increase the dose. Second thing, change it. If none of them work, then what you have to do is either go for symptomatic relief, pharmacotherapy, CNS targets, or go for peripheral modulation of smooth muscles and give drugs connected with that one. And if there is a cure, then regenerative medicine, growth factors, gene therapy, stem cell therapy, tissue engineering, it can be advocated for curing the people who don't have the effect of PDE5 inhibitors on them. They include so many angiogenic factors, platelet-rich plasma, stem cell therapy, adipose cell therapy, and replace defective therapy. These are the tissue engineerings available to cure the regenerative medicine, that is for the ED. Contraindications for PD. Who should not be given PD? This is a very, very important topic because all cannot be given PD5 inhibitors because there are some contraindications, especially if the person is taking nitrates for treating the chest pain. He should not be advocated the sildenafil citrate and PD5 inhibitors. One has got severe heart disease, it's contraindicated. And one who has got hypotension, they should not be given these medicines. And contraindications, recent cardiovascular event, taking nitrates, hypotension, anatomical deformity of the penis, angulation, cavernosal fibrosis, Peyronie's disease, predisposition to prolonged erection, sickle cell anemia, and multiple myeloma, leukemia. These are some of the contraindications for giving the PDE5 inhibitors. What are the side effects of PDE? Most of the times when the patient walks in, whenever we prescribe anything, the first question they ask is, sir, does this have any side effect? And second thing is, most of the people, they have got some misconception about the modern drugs, thinking that the modern drugs have side effects. These are all the false things spread by the other alternative line of medical line of treatment given by the others. These practicing homeopathy, Ayurveda, Unani, the Siddha, they always blame the modern medicines, say that these modern medicines, they have got side effects, don't take. Absolutely, it is nothing like that. All the medicines which are in the market, they are quite safe. And all the medicines, where anything given to the person, including homeopathic medicines or Ayurvedic medicines or Siddha or any other Unani, they may also have equal number of side effects. The only thing is those have not been studied properly. They will not admit the side effects. I have seen hundreds of patients who come with tons of tablets given by the other systems of medicines with side effects, but they never publish. Whereas modern medicine admits the whatever defects the medicines have, we tell them these are the possible side effects, and also we give the remedy for these side effects. And also another thing is, these are all published scientifically if there is any side effect. And if the side effects are more, immediately the Drug Controller Authority of India withdraws that drugs. So friends, you are in the safe hands with modern medicine. Don't be carried away by the wrong propaganda of the other systems of medicine. So always blame the modern system saying that they have side effects. Of course, any medicine which has got good effect may also have side effect. If there is no good effect, no side effect. And some of the side effects which have been listed by taking the PDE5 inhibitors are backache, facial flushing, headache, lightheadedness, dizziness, nasal congestion, upset in the stomach, that is dyspepsia, visual changes, blue halo, optic neuropathy, priapism. Friends, these are some of the side effects, but luckily, the side effects will appear with the first tablet itself, and just stop the tablet and change the tablet. That is done with it. No serious complications of life-threatening type have been observed with any of the PDE5 inhibitors. And sometimes erectile dysfunction and premature ejaculation go hand in hand. And those who have got premature ejaculation, they think that they have got ED because they would have ejaculated so quickly and the erection will come down. They will think that, I have got ED. It's not like that. Sometimes they coexist, and sometimes there will be only premature ejaculation. Once the ejaculation is over, there will be detumescence and refractory period for erection. and the person thinks that he has got ED. Other oral therapy other than the PDE5 inhibitors are apomorphine, sublingual tablets, yohimbine hydrochloride, that centrally and peripherally active alpha-2 adrenergic antagonist. And this hypertension, anxiety, tachycardia, headache, there are some of the side effects. And apomorphine, centrally acting dopamine agonist, it can cause nausea in about 12% of the people. And causes for failure of PDE5 inhibitors. Why some people don't respond to the PDE5 inhibitors? Most of the times it is incorrect use of the drug and incorrect timing and lack of sexual stimulation. Friends, the PDE5 inhibitors will never give erection. They just relax the smooth muscles of the penis and give the penile vascularity is increased. But the sexual stimulation should come from the brain of the person. Unless he is sexually aroused, PDE5 inhibitors will not work. So sexual stimulation is most important. Without sexual stimulation, PDE5 inhibitors themselves will not go to the penis and make it erect. This is one thing one should always tell. And when we give the prescription, we should tell that this tablet will work only if you are sexually stimulated. For example, a person who takes the PDE5 inhibitors in the mid-afternoon working in his office, if he takes even 100 mg tablet, erection will not come. That is because he's on work, is otherwise engaged. His mind is not towards the sexuality. That's why PDE5 inhibitors should be told that it is not an erection tablet. The erection should come from sexual stimulation. It will only enhance the erection by smooth muscle relaxation of the penile blood vessels so that the quality of the erection will increase. That is very important. And inadequate patient education and unidentified hypogonadism, anxiety, performance anxiety, comorbidities, psychosexual factors, and severe ED presentation. These are the patients who don't respond to the PDE5 inhibitors. So friends, as I told in the beginning itself, at the diagnostic level itself, the concomitant factors, the other factors which are the causative factors for ED must be addressed so that the effect of whatever medicines is more effective once you rule out the main cause. And management of non-responders, patient education, improved related comorbid conditions, normalizing the testosterone level, switching the PDE5 inhibitors to one to another, increasing the dose, daily or continuous use of PDE5 inhibitors, psychosocial counseling, and combined therapy, that is combining two medicines or three medicines together. This is how the PDE5 inhibitors, the management of non-responders has to be done. The next is the injection therapy. The most important injection is the testosterone, androgen replacement. Androgen deprivation has been shown to result in impairment of nitrous oxide synthase release, altered PDE5 expression and activity, impaired cavernosal nerve function, and contribution to veno-occlusive disease in the penis. So friends, testosterone plays a very, very important role in erection. That's why testosterone replacement helps a lot. And also it enhances the function of the PDE5 inhibitors. Androgens are known to have a significant impact on the function of smooth musculature within the corpus cavernosa. That is why when we give the PDE5 inhibitors along with one dose of testosterone, it enhances the action of the PDE5 inhibitors. Androgen deprivation has been shown to result in impairment of synthase release, altered PDE expression and activity, impaired cavernosal nerve function, and contribution to veno-occlusive disease of the penis. The role of testosterone as a potential to improve erectile function in the man with ED remains an issue for patients and physicians who are comfortable treating the androgen deficiency, which include primary care of the physician and specialists. Androgens are also known to have significant impact on the function of smooth musculature of the corpus. So the next type of injections are intracavernosal injection. In other words, intrapenile injections. That is injecting directly to the penis, that is into the cavernosa, is intracavernosal injections. Injections available are alprostadil 5 to 40 microgram, independent of contact nervous system, manual dexterity, adequate vision. Training should be given. Contraindications are bleeding disorders, sickle cell anemia, multiple myeloma, and leukemia. Side effects are penoscrotal pain, hematoma, fibrosis at the site of injection, and priapism. The other injections available are papaverine, phentolamine, iviptadil, that is vasointestinal peptide. They are also that that can be given sole or with alprostadil. So these are the injections available. Alprostadil, the dose is 5 to 40 microgram per injection. Papaverine 30 to 60 milligram. Phentolamine 0.5 to 2 milligram. Aviptadil 25 microgram. And these injections can be given in combination also, bimix, trimix, or quadramix. Mix 1, 2, 3, 4, all the 4 quadramix. Mix any of the 3 trimix. Mix any of the above 2, that is bimix, or solo injections. Friends, this is how the injection is given to the site of this one. They select the 2 sites either at 2 o'clock or 10 o'clock, directly inject into the corpora, and you can see the needle directly placed in the corpora. Self-injections, injection can be loaded and handed over to the penis up to the patient, and he should be trained well so that he injects directly into the spot that is into the corpus cavernosa. And the side effects are injection site soreness, priapism, that is prolonged erection, penile pain, possible scarring or infection at the site of injection. These are some of the side effects of the injections. And alprostadil creams are also available. Creams, jellies, and pastes are also available. They are also available as suppositories. Alprostadil urethral suppositories are inserted into the urethra with a special applicator. The side effects include pain and minor bleeding. Alprostadil can also be applied as topical cream, but it is not available right now. This is how intraurethral alprostadil is inserted into the urethra. And what are the alternative managements available? We have covered the medicines and we have covered the injections. Now the next level is the alternative medicines. Penile rings are available. That is popularly called as cock ring. It's a circular sex toy that has to be applied into the base of the penis, and also it can be applied over the penoscrotal region also. It is called as penoscrotal ring. And the cock ring applies pressure to the penis and surrounding area to trap the blood in the penis for longer time. That's how the erection is achieved. In fact, it's called as cold erection because the penis, when you touch, it will be cooler than the expected warm penis of natural erection. And it helps the penis become firmer and erection will be last longer. Other than the penile rings, external penile prostheses are available. They can be worn over the penis and perform the intercourse. There are several types of penile prostheses, extenders, support devices, external prosthetic phallus. They are more affordable than the other methods. They are non-invasive, easy to get without prescription. And penile sleeves that can be worn over the penis. It looks like life-like shape and color also, and external size can be made to customizable fit. That is, it can be exactly given to the person taking the correct measurements. They are made up of skin-safe silicone, and they come in different colors and tones so that you can choose the color and tone which matches with your penis. They come in different firmness levels to accommodate people who can maintain erection and those who can't. They also take custom order. The sleeves are attached to an adjustable harness, and that keeps it in the place during the penetrative sex. The next alternative available is the vacuum pump. Several alternative medicines treatments are available. Platelet-rich plasma, low-energy shock wave therapy, acupuncture therapy, vacuum pump, penile rings, which I've already covered, and vibrator therapy. Vacuum pump devices that trap the blood into the intracorporeal and extracorporeal compartment. Constricting ring is applied to the base of the penis after getting the erection. It may cause cyanosis, edema, and it may cause the pivots at base below the ring, and you should not use for more than 30 minutes. Vacuum constrictive devices consist of a shrink ring, a cylinder pump. It employs negative pressure to dilate the cavernous venous sinus, increase the perfusion of the cavernous artery and venous blood, and ultimately achieve the goal of producing penile erection. An external ring is placed at the base of the penis to prevent the blood flow during the intercourse in order to maintain an erection. In other words, once the erection is achieved by applying the negative pressure, that is a vacuum, the blood trapped in the penis must be withheld so that it will not go back by putting the penile ring, which I have already shown you earlier. It used to promote the recovery of the penis function and maintain penis length also. So friends, this is how the vacuum constrictive device works. That is along with the vacuum. Once the penis, the vacuum is created, there will be erection and you have to put a constrictive device to the base of the penis. In addition, the device can only increase the oxygenation of the corpus cavernosa, and also method can bypass limitations of oral drugs and directly achieve artificial erection, but it requires a normal intact cavernous nerve to produce an erection. If the cavernosa nerve is damaged, erection may not occur. Compared to other penile rehabilitation therapy, the vascular constrictive device therapy has advantages of being non-invasive and having fewer systemic side effects. The other alternative medicines, the other alternative therapies available are the acupuncture, which has been widely used in China in clinical trials. There are many clinical trials that confirm that acupuncture can improve the penile erection. It is called as impedance in traditional Chinese medical system. Some TCM methods are frequently used to treat it, and most commonly used method is acupuncture. In fact, acupuncture is the umbrella term for acupuncture and moxibustion. Acupuncture is the procedure of inserting fibriform needles into the specific point of the patient's body, known as occupines, and using acupuncture techniques such as twisting and lifting to treat the disease. Occupines can control and regulate the flow of QI as well as its distribution and excretion into the viscera in order to maintain the balance between internal and external environment. Friends, I have tried the acupuncture in several patients. The results are quite encouraging, but the only drawback is we would have treated the patient not just with acupuncture, but with several other treatments. So acupuncture may not be the sole treatment which has acted on the patient. It is definitely one of the side work that we'll do. And in the comprehensive care of the patient, we require so many gadgets, and acupuncture is one of them, and it is quite useful. The other treatment options available are low energy shock wave therapy, LESWT, also called as low intensity shock wave therapy, that is LISWT. So LESWT had recently been developed for treating the ED, and it is there from several years. And it is shown that LA is unique in that it aims to restore the erectile mechanism in order to enable natural or spontaneous erections. How it works is it causes cellular microtrauma, which in turn stimulates the release of angiogenic factors and the subsequent neurovascular factor, the neovascularization of the treated tissue. This is how the LESWT is released into the tissues, and from the transducer, the sound waves, that is low energy shock waves, are released into the skin, which goes deeply into the organ and causes neovascularization. It is the treatment consists of non-invasive, low-intensity sound waves that pass through the erectile tissue, restoring natural erection function by clearing plaques out of the blood vessels and encouraging the growth of the new blood vessels. It offers a cure in that it reverses the problems that cause the dysfunction. The most desired win-to-win outcome covered by the men with ED. The other types of alternative treatments are available are electric stimulations is one of the emerging technologies. It is still in infancy stage, and it's a physical method that relies on the output of low frequency pulse current electricity to treat the disease, and is now widely used in urology, male surgery, GI injury, A surgery, O and BG. Especially in the field of treatment of VD, increasing number of studies have shown that use of electrical stimulation technique can achieve good positive outcome. Penile vibrators, they are also shown to give adequate penile stimulation to give the erection. Vibration is positively correlated with increased sexual desire and overall sexual function. It is a potential treatment for sexual arousal difficulties and pelvic floor dysfunction. Genital vibration is a potential treatment for sexual dysfunction. Now, we have exhausted all the techniques. If the person doesn't respond to any of the above techniques, the last resort is the surgical method. It is indicated for management of VD refractory to all other managements which I have already enlisted. And one of the earliest contemporary surgical approach to ED was described by Houston in 1902. Now, so many developments have taken place and processes have come to the picture. Modern penile processes came in during 1970s. Prosthetic surgery, prosthetics, when there is lack of efficacy or dissatisfaction with medical management of PE, penile prosthesis placement is the procedure of choice for restoration of the penile rigidity. Penile prosthesis surgery is irreversible in that carpal tissue is permanently damaged and it can never come back. That's why it should be kept, the surgery should be kept as the last option, not in the first option. Because once the prosthesis is introduced into the cavernous is also all completely damaged, and this damage is irreversible. Even if the prosthetic the rod is taken out, absolutely there will be no erection because we have artificially destroyed the corporal tissue. Contemporary processes which are available in the market include semi-rigid, that is called as malleable silicone rods, 2-piece inflatable hydraulic pumps, and 3-piece inflatable hydraulic pumps. These are the 3 popular types of prosthetic surgery for penis available in the market. Counseling the patient is very, very important. We should tell frankly what he expects and what he can get it. Most of the patients are under the impression that by putting the prosthesis, the penis size is increased. It is absolutely false. We cannot increase the penile size by inserting the prosthesis. If you want penile lengthening surgery, the lengthening surgery is entirely different. And whereas the silicone rods or the inflatable bulbs we are going to put, they are not going to increase the size of the penis, but they are going to retain the original size of the penis. The only thing is the erection is already there. This should be clearly told to the patient. This is how the malleable processes look. There are 2 silicon rods and they are intertwined with the metallic core. The advantages are they are easy to implant, more economical, easy to operate, and have less mechanical parts. That is, the failure rates are very low and minimal risk of mechanical failure because the surgical rods are quite simple. Disadvantage of silicon rod, major disadvantage is semi-rigid devices is that the penis will never be fully rigid or fully flaccid. That is, in other words, there will be always semi-erection with the silicon rods. These devices may interfere with urination, a difficulty to conceal, and have a higher likelihood of device erosion. Malleable processes is most commonly utilized in resource poor settings and for the patients who want device with minimal complexity. The next generation the penile processes are the two-piece inflatable processes. Two-piece inflatable process consists of pair of cylinders attached to scrotal pump. That is, there is pair of four cylinders and both are connected with the scrotal pump. They are the two units. That is, one unit is the parallel cylinders. That is one unit. Second unit is the pump, which is going to be placed inside the scrotum. These devices represent a compromise between the use of placement and potential for expansion. This is how the two-piece pump works. Processes can be deflated by bending the penis. While these devices permit some appearance of flaccidity, the lack of separate reservoir does limit the amount of detumescence that can be attained. In other words, the penis is better than the silicon rod implanted penis because it can be easily folded and the fluid can be sent back to the reservoir by squeezing the penis. The next one is the three-piece. That is, this is most popular implant surgery, and it is the gold standard for treatment of medically refractory ED because there are three pieces. That is, one, the cylinders which are placed in the corpora. Second, the pump which is kept in the testis. And third one is the reservoir which is kept in the suprapubic region. So how it functions is when the person pumps the pumping machine which is kept in the scrotum, it inflates the cylinders by drawing the fluid from the reservoir. And when the job is finished, when the penis is deflated by opening the valve again, the fluid will go back to the reservoir. So reservoir is kept in the suprapubic region. So that's why it is called as three-piece inflatable processes. So this is how an installed processes looks. It provides excellent rigidity when erect and a more natural appearance it gives while in flaccid. When fully erect, they are as rigid as the two-piece cylinder, and it is in flaccid stage, they surpass flaccidity of two-piece processes. The results are excellent. About 90% of men are happy with prosthetic surgery. They have been observed from past 10 to 15 years, and most of the men are quite happy, and the satisfaction is due to the capacity of processes to allow for spontaneous and repeated reliable erections without external medication or devices. However, men willing to undergo implantation of penile prosthetic are self-selecting group and may not be representative of the general population. So complications, just like any other surgery, there are complications. The infection is one, and they may be rejected, and there may be the illusion, and especially people with diabetes, they are the very high risk patients who can get the infection very easily. So any diabetic patient, you should see that you don't operate on them unless the blood sugar level goes below 200. Arterial revascularization, if there is any narrowing of the blood vessels, then those narrowed blood vessels can be opened up by arterial revascularization, that is restoring the normal erectile function. Venous surgery. The venous is the deep vein ligation is the main treatment as far as the venous surgery is concerned. By ligating the deep penile vein, the blood trapped in the penis will remain for longer time, and one may have the successful intercourse. One thing I wanted to tell is this venous surgery and arterial surgeries are not recommended as standard methods of treatment because the failure rates are high. And revascularization of the techniques, if the vessel which is narrow, if it is found out, then revascularization can be done. Anastomosis of the epigastric artery to the dorsal penile artery can be done. And deep dorsal vein ligation, the vein is a common approach. Contraindications for arterial revascularization. Peripheral penile arterial insufficiency is most frequently the result of general atherosclerosis. That is why those who have got general atherosclerosis, no point in doing this surgery, because if you just do the recanalization, vascularization at one point, when the blood vessel is entirely damaged, and once the blood vessel is fully damaged, the surgery doesn't work. So adverse effects of surgery, most frequent effect is with penile arterialization is glands hyperemia, and it can occur in 30%. Other complications include infection, hematoma, thrombosis, and anastomosis. So vascular stent, just like cardiac stents, vascular stents can be done, but the only thing is the penile artery may not be narrowed at one point. The endothelial dysfunction can be there throughout the penis. So just by putting the stent at one point, it may not help and give the successful results. Complications of surgery, just like any other surgery, there are complications that vein infection and failure and other misplacement of the rod and the rod coming out, all possibilities are there. And coming to recent advances, melanocortin receptors are being tried, stem cell therapy, gene therapy, and platelet-rich plasma are being tried for ED. PRP, I'm happy to state you that I was the one who introduced the platelet-rich plasma in the year 2016 at Singapore in the World Association of Sexologists, and it was adjudged as the best research for that year in the field of sexual medicine. And now it has become very popular. And PRP involves taking the blood, centrifuge it, separate the platelet-rich plasma from the blood, and injecting it into the penis to promote tissue growth and give better sexual performance. So PRP male enhancement, also known as platelet-rich plasma male enhancement, is non-invasive, patented medical procedure designed to improve man's sexual performance, increase performance, and obtain optimal penis size. The use of PRP speeds up the neovascularization and therefore increase the blood supply and nutrients influx necessary for cell regeneration in the damaged penis. Stem cell therapy is still in the infant stage and it is in the research, and injecting the stem cells into the penis has been shown to give better erection, but still a lot of studies have to be done in this field. Gene therapy, replacement of gene therapy, this novel therapy still is in the research phase. I hope that the research will be successful and in near future, we will get gene therapy as a standard procedure for the treatment of ED. So future ED treatments, currently available treatments, side effects underlying the cause, that is why research exploring new avenues of treatment. Let us look at the latest ED treatments and some innovative therapies that are available in the years to come and what will come next. So in a nutshell, diagnosis of ED by taking history, taking examination, lab, and underlying psychosexual dysfunction should be studied. And if the normal values or lab are there, then go for the treatment. If hormonal immune deficiency is there, then go for hormone replacement therapy. If there is an underlying psychosexual dysfunction, go for sex therapy. And if there is the results of the lab are normal, go for the PD5 inhibitors. And high risk, if the patient is high risk CVD, go for CV evaluation. And in the first line of therapy, if there is no response, go for the higher treatment, go for second line of injections, that is vaso-erectile devices. Then if the response is not there, go for the third line treatment, that is penile implant surgery. So this is the flow chart for the treatment of ED. So friends, to conclude, most important treatment for the erectile dysfunction is first find out the cause and eliminate the cause. If there are risk factors, eliminate the risk factors. If there are comorbidities, first treat the comorbidities. Then come to the lifestyle changes and risk factor modification that proceed the ED treatment. Unless you change the lifestyle of the person, if he is in the bad habits, there is no point in giving PDE5 inhibitors for him because they don't work. And even if they work for a very short time. When a curable ED cause is found, cure it. And inadequate, incorrect prescription, poor patient education are the main causes of lack of response to PDE5 inhibitors. Penile implant is the last line of treatment that should not be advocated in the first line, because if the penile implant surgery fails, nothing else can be done. We would have damaged the corpora in such a way that no medicine on this earth will work, because the corpus, that is the spongy tissue, is damaged. And if you don't ask your patient, be embarrassed. So thank you very much for the kind attention. Dear doctors, it's a great pleasure to be with you, IGCP people. They are doing human service by spreading the education, especially during this time when, after post-COVID era, the doctors are now more reluctant to go and attend the seminars, lectures, and go for the conferences. For 2-3 years, that was disconnected. Now, again, going back to those days of going to the classroom and sitting are vanishing. That's why these online lectures have become very popular. And IJCP is doing human service in this field, taking us to the field of medicine and treatment by calling the experts in their own field and share their experiences, and they spread the awareness, especially in the field of sexual medicine. Thank you very much. Thanks. And also I thank the IJCP authorities for giving me an opportunity to address you people. If there are any questions, I'll be very happy to answer. Over to Faraz.
Yeah, thank you so much, sir, for taking out your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. So we have received some question from the participant, and with all your permission, shall we take this
Oh,
question?
yes, oh, sure, sure. Pleasure will be
Yeah,
mine.
the question is that can ED cause preonile disease?
ED cause Peyronie's disease. Yes,
Yeah,
possible.
exactly.
Yeah, because erectile, the Peyronie's ED, in fact, the first phase of Peyronie's disease is ED only. It starts as an ED. It will immediately, the plaque will not be seen. It will be soft, fibrous stage. In that fibrous phase of Peyronie's disease, only ED will be there. After few months, the plaque will appear and it will be palpable. So ED can lead to Peyronie's disease.
Okay, thank you so much for answering it, sir. Moving forward, the another question is how is comorbid cardiovascular disease treated in men with ED?
This I had covered in length in the last lecture. Please share the last lecture to the person who has asked this question. I had told very clearly that cardiovascular disease, CVD, and ED, they go hand in hand, hand in glove. So in fact, the ED is the predecessor for the incoming cardiovascular disease. So both are 100% related because both are of vasculature in nature, and the same treatment which we give for the cardiovascular disease are to be given for the person who has got ED. So please go through my last lecture. You will get extensive analysis regarding the comorbidities, that is CAD, CVD, and ED.
Okay,
Please
thank
share
you
with
so
me.
much for answering, sir. I can see there is, yeah, sure, sir. And we will be sharing the lecture to them. And the another question is what is the role of interconventional injection in the treatment of ED?
Now, that's a very good treatment. Second order, I told you, if the medical line fails, that is, if the oral medicines, that is PD5 inhibitors, all these fields, that is the tadalafil, lavanafil, udinafil, and sildenafil, if they fail, then start the penile injections. penile injections can be handed over to the patient also, treat him and teach him so that he takes the injection 15 minutes before the intercourse and he enjoys the sex. And that is one of the best line of treatment if the oral medicines fail.
Okay, thank you
The-
so much for answering it really well, sir. I can see there is one last question that how is the restorative therapies effect in the treatment of ED, and does testosterone improve in the response of PDE51 in men with ED?
Yes, that is a very good question. In fact, just if you go through my last the slide which contained about the this one, the testosterone, I have very clearly told that the testosterone plays a very important role in penile erection by smooth muscle relaxation. That is, it enhances the action of PDE5 inhibitors, especially if the testosterone level is below the mean of the patient. That is, for example, we have the range of testosterone, say about 166 to 923 international units of testosterone. And if it is below 550, then we can say that it is below average, not low. It is not called as hypogonadism. It is below the mean of the acceptable level. Then you can give testosterone replacement therapy, that is that HRT, hormone replacement therapy in the form of testosterone, that will definitely enhance the action of PDE5 inhibitors.
Okay, sir. Thank you so much for answering all the questions really well, sir. As I can see, there is no more question from the participant end. With all your permission, shall we conclude this session?
Oh, yes, thank you. I think we have stopped in the exact time, that is now, I think, 3:31.
Exactly, sir.
So the questions were excellent, well, and also the type of questions I got that shows that all the participants have gone through all the slides very attentively and pointed out the questions where some element of doubt has occurred. That shows the quality of the audience we had. Thank you very much once again. Thank you, AJC people. Thank you for us. Thank you. Bye.
Welcome, sir. And sir, it was really nice and hope to see you again with different
Oh, yes,
topics, sir.
sure,
And
sure.
till
Next, I
then,
will come
take
out
care of
with
yourself.
premature ejaculation.
Exactly, sir. Until then, take care of yourself, sir. We are closing here. Thank you.
Thank you. Thank you.